Thank you. Good afternoon, everybody. This has really been a very, very exciting day, and it's really great to be at this kind of inaugural conference of this really new organizational structure to help really build and extend population health science, hopefully in less than the 10-year challenge that Dave just gave us. So I'm going to talk in my 20 minutes about, from a funder's perspective, around the kind of research and evidence and knowledge building that we need to do in the terms of that we're talking about it now at the Robert Johnson Foundation to build a culture of health. But I'm going to say throughout this presentation that's what we're calling it, and the framework that we've developed to understand that for ourselves, and we think that's going to be helpful to the nation, is that this is the nomenclature is one way. As I give this talk, think about culture of health as another way to talk about collective impact strategies that communities use to build well-being. And we have found in the couple of years that we have been doing a lot of fundamental community listening around developing this model. Well-being as a concept provides the kind of connection that we need to a variety of sectors to do this work. So I'll present kind of what we've been doing, this framework, which is both our strategic framework for all of what we do at the foundation, but we think is also an action model, a framework that helps guide some of the important issues that we should be addressing in population health science. And if there's anything that's the basic science to what we're talking about as a culture of health, it would be population health science, and we very much are supporting that and very happy to be supporting this conference. So if I can work the AV, I can. Good. So I'm going to talk about how we develop this action framework to build a culture of health. It is impossible to give a talk, and you wouldn't want to hear one on all 41 of those national measures. It would be a very boring talk, but I would refer you to www.rwjf.org/action framework, one word, where you can see this report that we're going to be releasing at APHA in Chicago in about a month, along with the new website, cultureofhealth.org. So and you'll be able to see those measures. I'll mention just some of those now. Because I'm going to talk a lot, and we've talked a lot about this national framework for building a culture of health. I'll speak a little bit about the many different kinds of community level activities that we're doing, and particularly the Sentinel Community Study, which we'll be again announcing at APHA, which is kind of a local proof of concept to see what these kind of collective impact strategies look like that reflect the diversity of places around the nation. So I'll talk about that. And then hopefully we'll have time at the end of all of our presentations for some questions. So again, developing this action framework, it required both rigorous research and rigorous listening to a variety of stakeholders who not just study the problems, but experience the kind of problems we're trying to resolve. Certainly, the social determinants of health and improving equity and health outcomes are probably the central components of this action framework. And in collaboration with the RAND researchers at RAND, particularly Anita Chandra there, we really spent about almost 2 years in developing this framework. And we asked one research question with sort of two subcomponents. What's standing in the way of the health equity we aspire to as a nation? The two components are, what do we need to know more about? And the second one, what do we really know a lot about, but we need to scale and spread? So with that as the frame for the work that we did with RAND, extensive review of the literature, really exhaustive. On the new website soon, you'll see what we kind of called Deliverable 1. Not a great name, but it will be the summary of all the basic research that we did to develop this framework, and that'll be available for you to look at. Extensive review of all of that. A lot of engagement with communities around the country, 13 different cities where we did concept mapping and a variety of other things, just to really try to understand what was meaningful to communities around improving their health. And that's where we really learned that this framework of well-being was particularly important. All of this came out of, and I think some of you may have seen our president, Lisa Moray, and the board's 10 principles principles for building a culture of health, these aspirational principles that led to this more analytic work down the line. And I encourage any of you who haven't been on our website to see that, to take a look at that. And as we develop this framework and a set of national measures, and I'll come to this a couple of different times. It will not look like Healthy People 2020. It is explicitly not intended to be an index. There are by design no weighting on the measures. It's a set of measures that are intended to, they're evidence-based, but they're intended to be a catalyst for a dialogue with those sectors that have to be involved in improving population health in a set of measures that are meaningful to them and guide the kinds of actions that they might take to really improve some of the social determinants of health. And I'll talk a little bit more about that. Again, this framework has been a framework for a number of new foundation research and programmatic initiatives, and I'll end with a number of the new opportunities, particularly on the research side. And I want to make sure that it's all that you understand. It's beyond that. We think it's a framework that will be useful to many other partners, academic partners, community partners, to find themselves in this framework around what we can do to improve well-being and equity in healthcare outcomes. So it's not an initiative. It's the Foundation's complete strategy for all of what we do, and our board has made an amazing 20-year commitment to this being the framework to fund what we do. And the other thing before I get into it is it's a framework that absolutely assumes that the changes that we hope to see over those 20 years, we believe our grant making will contribute to that, but the scale of changes requires alignment and the resources of a variety of different partners. So on that. Okay. So here's the framework, and you saw Laura put this up a little earlier when she was talking in the opening session, when she was talking about the work they're doing at UCSF with one of our programs. So here's the framework, and again, I gave you the link where you can find this full report. I'll mention each of these action areas in a bit, but I want to first emphasize that improving health equity and equity issues are at the core of all of this framework and what we're trying to do. And these 4 areas seem to be starting from those 10 principles that the board and RESA came up with and the research that we did with RAM. These seem to be the cluster of areas, we call them action areas, where we either need to learn more about what to do or apply what we need to do in a more rigorous way. So kind of going through these, I think about this, and particularly those of you who do collective impact work in communities, these are the kinds of areas you really have to traverse if you're going to both develop the kind of community cohesion around valuing health. As many speakers have said today, the imperative of cross-sector collaboration, including health, but beyond the health sector, to improve well-being. Action Area 3, clearly creating healthier and more equitable communities, is an action area that all of these strategies go through. And then again, as was talked about a bit this morning, where you can't put the heavy burden or the exclusive burden on the healthcare system because this is the $3 trillion kind of entity in the room. You have to pay significant attention to what it means to strengthen the integration of health services and systems. So that's the framework, and I'm going to spend just a bit of time going into each one of those. This is Action Area 1, making health a shared value. When you see this full report, you'll see we think this is the most important area for further research in population health and one of the most difficult one. This is understanding the current narrative, popular narrative that drives health and well-being, and then understanding how you change that narrative. I mean, that's one way of thinking about it. And so we are in that area, and particularly some of the research programs that we've been launching, like Evidence for Action, really trying to understand the mindset and expectations of the American public around health, which, as we know, is often a default to understanding medical care or illness care actually may not revolve around health. How do we understand that better? And what are the drivers? All the action areas have a couple of drivers that came out of our research that we think are are very important drivers and areas where we need to learn more from a research base around how those drivers operate. Civic engagement and a sense of interconnectedness to community are very important parts of that. And when you see the report, you'll see we have civic engagement measures like voting and voluntarism, and then we have some other national survey data that RAND did to understand some of this national sentiment. But we think this is a really important area. The research body of this comes from social cohesion. My good colleagues in our communication side decided making health a shared value had more explanatory power to the groups we're trying to reach. But this is really based on a lot of the social network theory, social cohesion theory, and a lot of work that we really need to broaden our understanding and we believe is an important part of where population health research should go. The second action area, all day long, we've been talking about fostering cross-sector collaboration to improve well-being. And Jeff's remarks this morning really heightened. Talked about how that prevention report that he presented from that group, trying to develop cross-sector collaboration between bureaucratic silos, clearly working across those silos, whether they be sectorial or whether bureaucratic, is a real key part of this. These kind of problems that we have around inequity and outcomes in health in this country really require different kind of collaborations, because kind of the correlate of 70% of health being driven by non-health factors means you need to involve those sectors and their assets in the solution. So in this area, and you look at the whole report, you'll see that we have drivers and measures around the kinds of partnerships that are trying to drive this action. And we need much more research around not just having community partners, not just having community health assessments, but what difference do those make in terms of policies that can influence population health. So we have measures of resource investments across sectors to track whether rhetorical alignment to this is matched by actual resources put into those collaborations. And then policies, both governmental and corporate policies, that support the kind of collaboration for improving health and well-being. We've got a number of those measures. One of the interesting ones I thought I'd highlight, since they came up a bit today, was we had one of the measures we worked with the American Hospital Association to develop, and it is a measure about a collaboration between hospitals and communities that go beyond the IRS minimum requirements. So we've worked with them to develop an indicator that appears in this draft, but it'll be much better than the next one because we're using their whole CEO survey to really try to incentivize that whole sector to go beyond the relatively limited requirements of the IRS to do those community assessments in collaboration with public health and other entities, and to work with their constituency to understand how to do that in a much better way. So that's an example of a measure that we think indicates the kind of cross-sector collaboration that we want to look at. We have another measure in there just so we understand some of the different places we're going on, whether sort of a national measure on the extent that full-time sworn police officers are appropriately trained in community policing. I mean, that's community policing. That's not stop and frisk. That's or broken windows. It's community policing. So those are some examples about that. I might just mention now the foundation is very engaged in partnering with organizations to demonstrate and try to understand how these cross-sector collaborations can really improve health at a local level. Maybe in the Q&A we can talk more about that, but that includes people like the United Way, AARP, La Raza, NAACP, YUSA, that are beginning to align their work around this kind of framework, which for a foundation in what we consider to be an evidence-based social movement gets us at a retail community level that we don't go to naturally, and is a very important part of the action strategy. Action Area 3, which we've been talking about all day, and all of you are working in it, is, how do you create healthier, more equitable communities? Often in public policy discourse, we get tied in knots about individual responsibility versus social context. Well, there are individual responsibilities to make healthy choices, but you have to have that choice, and you have to have a social context where that healthy choice is an easier choice. So the measure in this Action Area 3 and the research that we're supporting around that is really trying to understand what do you have to do in the built environment, what do you have to do around social and economic environment in order to have more equity in the ability of individuals to make healthy choices. And we have a measure in there from the NIDA survey, that's on youth perception of youth safety in the neighborhoods that has impact on well-being in a number of different ways. We break that down by race, and it's not surprising to this group that African American and Latino youth, school-age youth, have 2 to 3 times more likely to feel unsafe in their neighborhood, and it has broad implications. Again, action area 4, strengthening the integration of health services and systems. Laura talked really nicely about that this morning from the examples that they're doing in San Francisco. Absolutely key to research how we can integrate health service and systems, public health systems, in ways that drive toward prevention, that integrate the social service side in the way Betsy Bradley has written about it. Our last year's commission report from the foundation really talked about health systems needing to acknowledge and systematically address the realities of their patients' lives and really be reoriented around a value proposition. So we're very interested in this area, funding research and aligning our programs around access drivers, and we call out access to dental health and mental health in some of those measures, consumer experience and quality, and then really balance and integration of services. So that's an important part of this. I think it's really critical, but work that we have a number of different funding activities involved in that area. But we think that's key. So again, 20 years, and assuming that these kind of partnerships continue, and this is a moment I'm going to say would be a whole lot of hubris if we thought this could happen in 20 years and it was starting with our framework. We believe, because so many things are happening around the country in many ways in different places, a lot of these collection action strategies, a lot of innovations in different ways in states and locality, that if we can catalyze that, develop this kind of alignment, incentivize that with some of our funding and alignment with some other fundings, we can make this long-term improvement in population well-being and equity over this 20-year strategy. And when you look at the report, you'll see we have a number of longer-term measures that we hope would change if we're successful at that. Again, using a well-being indicator from the European Union because we really want to emphasize well-being. We see one of the measures we picked was a dramatic reduction in ACEs, and you heard that in this morning's presentation. The power of being able to eliminate adverse child events would have on healthy life course for populations. So that's the long-term outcomes. When you look at the measures, recognize when we got with RAND probably 200 possible measures, but again they were selected based on that they were national, not just ones we wish we had, that they applied to the entire lifespan and health span, meaning a culture of health means everyone maximizes their health even if they have some existing disabilities. Broad determinants and upstream drivers, so our measures really focus on those social determinants more so than the morbidity and mortality correlates to those, that they can engage audiences beyond health, that was an explicit criteria, and that they drive to more equity in our system. I'm getting to the end. All right, so a lot of time thinking about a national framework. What does this look like at a local level? We have this isn't the only community project that we're doing in the foundation. There's lots of them, but I want to talk about this one. We'll be launching this one at APHA 2 in Chicago. We've selected, and we've been invited by 30 communities around the country that we reached out to understand what does the wide variability of this country look like around these collective impacts strategies for health. Not best practices, just many communities are where they are and how can we learn about them. Jeff again said this morning, some of these models are not transportable, but the strategy of the Sentinel communities is to look at enough diversity of how these things are happening in communities. We're going to look at them about 10 years and lift up and understand how what barriers they face, how they develop collective action strategies, and what impact that has on population health. And I'm not going to give all the names of it. Many of you actually are here, are in communities where we're going to be, and you'll learn that soon. But they range from the Gulf, cities in the Gulf states, the Northeast and Northwest, many different kinds of rural communities, a large Indian Indian nation in the Southwest, all where we will be understanding in a mixed method approach how varieties of partnering and collective impact strategies impact well-being. This will not affect opportunities for foundation funding. That means it's not a place-based strategy where we're putting in a lot of programmatic money, but it doesn't mean that they are excluded from other funding opportunities that may come along. I'm going to close with some of the new research activities that we're doing that are aligned with the culture of health. We launched 3 new ones this year, as well as aligning the entire Foundation's research work around building the evidence base for a culture of health. And so let me just talk about the 3 that are launched. We're really interested in developing, and this is our Evidence for Action National Program Office at UCSF that Laura mentioned this morning, new research topics and methodologies that span many different disciplines. You'll see in all of our new research announcements kind of an imperative to work with transdisciplinary teams and teams that also connect to community members. So you'll see that, and we're getting lots of letters of interest for that program. And unlike a lot of our research programs in the past, when this is continuously open, you can send that group a letter of intent at any time. It's rolling. And that's our experiment in really trying to be much more timely and responsive in doing that. So that's Evidence for Action. Policies for Action, that's a program that's based at Temple. It had been our health law program. We've expanded that to really trying to understand policies and laws that have a potential to improve a culture of health. Kind of a strategic science of what health and all policy means. The RFP, I think, for the research hubs that will go with that NPO, kind of another new model we're doing, is out there now, and I think some people in the room are competing for that, but there will be a really good opportunity with that program to really understand actually a lot of what was talked about in the previous section on kind of systems science and strategic science for policy engagement. The last one, better alignment and delivery of financing systems within public health and healthcare systems. That's an evolution of Glenn May's program at Kentucky that was public health systems research, which is now looking at just the systemic relation and collaborations between public health, other sectors, the community, and really understand how we get this better alignment in the delivery and financing of systems that lead to better health outcomes and more health equity. So those 3 are on the board, but there is just again, within the foundation, many opportunities to apply and address some of the questions that have come up in this meetings over this day to build a culture of health and advance our work in population health. I put this slide in here, even though around our new human capital programs, which we're calling Advancing Change Leadership, understanding full well as a 10-year member of the National Advisory Committee for the HSS program that many people are in different stages of grieving about the programs that have been eliminated. So I'm not backing away from that one. I think you can see from the overall framework of what we're trying to do with the culture of health, we felt we wanted to figure out how to develop leaders that were aligned to that. The NPOs for those programs are going to be decided this week. And they are the Interdisciplinary Culture of Health Research Leaders, which I think is built on the shoulders of HSS. That's my sense from the inside. The new clinical scholars, which is adding other individuals who have terminal clinical degrees, nurses, social workers, PT, OT, into that mix because that kind of team care context is so critical for now. Diversity and Health Policy Research Program. That's a predoctoral program to bring individuals into really population health science and health policy science who are underrepresented, and then multi-sectoral leaders, not so much a research program, but to develop a cross-sector, this ability to work across sectors and disciplines effectively to build a culture of health. So again, I think that the many good things that we learned in the previous approach to human capital, we've tried to capture here with a rationale that the new structure will allow us to train substantially more individuals. So I'll end with this, and I encourage you to get on our website because Risa has put on a letter to the field. This is the first time we've kind of crosswalked our new sort of team and portfolio activities that all relate to our building of cultural health strategy, but this will give you a name, and on the website you'll see a contact person for each of these areas. So achieving health equity, we have a cross-foundation team all around, this for the former disparities team, all around achieving health equity that has its own research agenda, and I encourage you to explore that. Advancing change leadership, I just mentioned. A focus on bridging health and healthcare, that really relates to a lot of what I said around systems integration between public health, healthcare, community health. There are many research opportunities there. Catalyzing demand for healthy places and practices. That's where a lot of our work on the built environment, our new work that I know some of you in the audience have been involved with with the Federal Reserve and working on how we can improve affordable housing in urban areas without gentrification. That's there. Whole new interest in engaging business and health and understanding what kind of business corporate partnerships can actually make a difference. We'd have a new, it's actually not a new program, but we have a global team that is looking at how we can learn from other countries and scale and spread the issues there. Obesity work you know about, focusing on childhood obesity, strengthening vulnerable children and families, access to care. You can read it. I'll just flag Pioneer. Our Pioneer portfolio also takes rolling applications all the time. So that's where we are, and happy to really be here. Very exciting to see this society come to this particular role with this first conference. Great ideas today. It's been a pleasure to be here. Thank you.